Hello, everyone, and welcome to today's webinar for mental health professionals, Cognitive Behavioral Therapy for Chronic Gastrointestinal Disorders, featuring Dr. Melissa Hunt. My name is Astrid Masfar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop. You have joined the presentation listening using your computer's audio system by default. If you would prefer to join over the telephone, just select phone call in the audio panel and the dial-in information will be displayed. You may download today's PowerPoint presentation by clicking on the Materials tab on the webinar platform. You will also have the opportunity to submit text questions at any time during the presentation by typing your questions into the chat box. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation. You will receive a follow-up email including the webinar evaluation, webinar recording, and post-test assessment for those seeking CE credits. You will also have the opportunity to complete the post-test assessment after the presentation. The questions will appear on your screen and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce Dr. Melissa Hunt. Melissa Hunt is a licensed clinical psychologist and serves as Associate Director of Clinical Training in the Department of Psychology at the University of Pennsylvania. She is a fellow and a diplomate of the Academy of Cognitive Therapy and is proud to have served as a frequent program committee member for the Anxiety and Depression Association of America. Her primary research interests are in the domains of behavioral health and stress management, with a particular emphasis on individuals with chronic GI disorders. I'm now going to take a moment to pass the screen to our expert.
All right, hopefully you can all see this now.
Yep, perfect.
All right, so I'm going to jump right in. Thank you, Astrid, so much for that introduction. Welcome, everybody. It's a little odd not being able to see anybody, but we'll just go ahead. So I want to start by being upfront about the fact that I do have a very minor conflict of interest here. I am the author of a self-help book for IBS that is publicly available. It's for sale on Amazon and Barnes & Noble, whatever, and it's based on the theories and research that I'll be presenting today. Having said that, I want to tell you all that writing a self-help book is an absolutely terrible way to make money. You do it as an act of love and to disseminate an empirically supported treatment, not to make any money. Trust me, I'll never even make back my advance. So that said, here we go. So I want you to think about a new patient presenting for an initial consult and assessment in your psychology practice or psychiatry practice. This individual might have mild to moderate depression. They are reporting significant avoidance that absolutely looks agoraphobic. Cars, trains, planes, sitting in the back at church or at the movie, avoiding those things entirely. And they'll tell you that what they're really terrified of is experiencing an attack, but they're not really describing a full-blown panic attack. They may not have any cardiovascular or respiratory symptoms. They may not be dizzy. What they're really talking about is kind of gut-grabbing abdominal pain and sometimes an intense and urgent need to defecate. And that this just has become intolerable and they're afraid of being in a place where they're not going to be able to get to a bathroom. They may also have mild to moderate social anxiety, really worried about how other people are going to perceive them. If you've got all those pieces in place, they may very well have irritable bowel syndrome. So what are the formal criteria for IBS? IBS is considered a functional gastrointestinal disorder, meaning that there is no clear-cut tissue pathology, there's no infection, it's not an autoimmune disorder. The formal diagnostic criteria, which are promulgated by the Rome Foundation, which is a sort of independent nonprofit international group that looks at functional disorders. You've got to have abdominal pain at least 4 days per month or about once a week over at least the preceding 3 months associated with one or more of the following, that at least a third of the time the pain is related to defecation, that there's been a change in the frequency of defecating and a change in the form or appearance of the stool. That is, either they've got diarrhea or they've got constipation or they've got a mix of the two. And after appropriate evaluation, the symptoms cannot be fully explained by another medical condition. And that's really important because there are a lot of other medical conditions that have very similar kinds of symptoms, and they really need to be ruled out. The Rome Foundation actually changed the diagnostic criteria a couple of years ago to increase the specificity. Unfortunately, of course, by doing that, they've also decreased the sensitivity. Used to need pain only 3 days in the month, now it's 4. And it used to be described as either pain or discomfort, and now they really focus primarily on pain. So unfortunately, though, these criteria don't really capture the full burden of this disorder. In practice, IBS is often associated with urgency. That is, feeling like you need to move your bowels in the next 30 seconds. That's most true for folks with diarrhea, but it can actually also be true for folks with constipation predominant IBS, particularly if they're using a lot of laxatives. And in fact, they will often say they don't like using laxatives precisely because it triggers this feeling of urgency. A lot of folks with IBS are very, very afraid of fecal incontinence. And later on in the webinar, we'll actually get to the actual prevalence of fecal incontinence in this population. But it's really fear of fecal incontinence that drives a great deal of the avoidance behavior in these folks. A lot of folks also complain a lot of bloating, gas, flatulence. It is not uncommon for folks to come in and show me photographs of their bellies at some point after eating a meal. You know, it's almost like a pregnant woman photo, except it's a gas photo. So I will definitely see pictures of that from patients. Really, the main problem with IBS is that health-related quality of life goes way down. And that's due to a number of things. Avoidance, agoraphobia for sure. Also dietary restrictions and fear of food. And we'll be touching on that in much more detail later on. But limiting your diet has very far-reaching consequences for people in terms of their social lives and their work lives. So that really becomes problematic for people. Folks with IBS develop tremendous hypervigilance towards visceral sensations and a lot of anxiety. And similar to anxiety sensitivity, this is like visceral sensation sensitivity. And people get very anxious about the proximity and availability of bathrooms. So let's spend a couple of minutes talking about differential diagnosis, because it's really important to go through with a patient and make sure that they've had a good GI consult and that these other disorders have been ruled out. The main one that needs to be, the main two really that need to be ruled out are inflammatory bowel diseases and celiac disease. So inflammatory bowel diseases are autoimmune disorders in which there is absolutely visible pathology in the tissues of the gut, ulcerations, fistulas, inflammation. About a third of folks with IBDs are going to need life-saving surgery at some point in their lives, either for resection of a diseased part of the bowel or because they've had a small bowel obstruction because of scarring. The easiest way to do an initial screen for these is with a non-invasive test called the fecal calprotectin test, which is just a stool test, and it's actually quite sensitive to IBDs. But if it comes out even borderline positive, it's going to require follow-up imaging and biopsies and colonoscopies and so on. These are potentially life-threatening disorders that really need to be managed medically. Now, people with those disorders can actually develop secondary IBS even when the IBD is in remission, and we'll be talking about those folks a little bit at the very end of the webinar today. The next thing that has to be ruled out is celiac disease, which is genuine gluten intolerance. It's not sort of, you know, oh, I don't think people should eat wheat, so I think I'm gluten sensitive. No, this is genuine autoimmune mediated gluten intolerance in which, again, the cilia and the small intestine will be completely destroyed if people continue eating gluten. So folks need to have a blood test for that. There's also a genetic test that is becoming more available. The final one that's really getting more notice lately is bile acid problems. There are several different variants of that. It can be excess. There can be excess bile acid. There can be gallbladder dysfunction or removal, or you can get bile acid malabsorption. secondary to long-term non-steroidal anti-inflammatory use. So I really, really like to ask my patients if they've ever had a time in their life when they were really pounding the Advil or, you know, the ibuprofen or the Aleve, the naproxen. There's a known association between long-term use of those drugs and IBS. We used to think that maybe it was just because, oh, this is sort of a neurotic group with a lot of somaticizing, so they worry about pain. But it actually turns out that NSAIDs can cause not only gastric or stomach bleeding, they can cause enteropathy in the small intestine as well, which can lead to bile acid malabsorption. When you've got too much bile acid in the gut, it leads to massively increased water and electrolyte content and very watery, urgent diarrhea. There's no test for bile acid malabsorption that's FDA approved in the US. There are tests in Europe. But a trial of a bile acid sequestrant medication like cholesterol or Questran can be quite informative in those cases. And it's a super simple solution for people if that is what's causing their problems. Now, our gastroenterology colleagues also see these folks a lot. In fact, GI is where most of these folks appear. These are very, very difficult cases for gastroenterologists. These folks are coming in saying, Doc, you got to help me. There's something really, really, really wrong. But the gastroenterologist sort of does all the basic tests, blood work, and the fecal occult, which tests for blood in the stool, the fecal calprotectin for IBDs. They're going to look at gastric emptying and transit time through the gut. They're going to do methane breath testing to see if there's too much bacteria or lactose or carbohydrate intolerance. Even a colonoscopy and a capsule endoscopy where the person swallows a tiny little camera and it goes all the way through, magnetic resonance enterography, which is a special MRI of the gut, everything's going to come back negative. But the patient is increasingly distressed and anxious and frustrated and increasingly symptomatic. And the GI doc is just going, oh my gosh, I don't know what to do with this person. And I can tell you that a lot of the GI departments around here, that's when they call me and say, can you take this patient, please? There are really a lot of these folks in GI. Some estimate as high as 15% of tertiary care GI cases are really this, and there's very little that traditional Western medicine can do to help these folks. Okay, so there's a lot of psychiatric comorbidity with IBS. We know that. Stress often precedes the onset and is strongly associated with IBS severity and course. There's high comorbidity with a lot of different psychiatric disorders, particularly depression, panic disorder, agoraphobia. And it's worth noting, for those of you who have not read every page of the new DSM-5 super carefully, that the new criteria for agoraphobia allow explicitly for avoidance secondary to fear of not just panic, but other incapacitating or embarrassing symptoms, including fear of falling and fear of incontinence. And it's that fear of incontinence piece that drives a lot of the avoidance behavior for IBS folks. There's a lot of social phobia involved. People are terribly embarrassed. These are dirty, yucky, taboo problems. And people are very, very worried about other people finding out and thinking that they're gross or weird or awful in some way. So there's a lot of social phobia component. Generalized anxiety we see, also OCD and health anxiety. I actually have some very preliminary data from a study I'm doing this year that suggests that some of the more gas and bloating and diarrhea predominant forms of IBS may actually be linked to a history of contamination and cleaning compulsions in the person's family or in their parent that may lead to some disruption of the microbiome. So always worth asking about all of these disorders. Now, in contrast, inflammatory bowel diseases, which have a lot of the same kinds of GI symptoms, show much lower levels of psychiatric comorbidity, although indeed depression and anxiety may rise during active disease flares because it's a difficult thing to live with. So how do we understand IBS? You know, all the fancy, almost sort of sci-fi kinds of testing that our GI colleagues can do, they all come back negative for these folks. So what is going on? Well, really, it's a combination of a couple of things. Something a lot of us don't learn about when we're learning about the basic sort of, you know, autonomic nervous system is that the enteric nervous system, which is the part of the nervous system that innervates the gut in particular, is huge. It's got as many neurons in it as the entire spinal cord, and it's a very, very important part of the autonomic nervous system. One of the things we know about IBS is that the nerves in the gut start overreacting to all kinds of things. So really, we started to think about this as a centralized pain processing disorder. And with my patients, to help them understand that, I often use phantom limb as a metaphor. because they'll be telling me, yeah, but the pain is in my gut. Like I feel it here in my abdomen. And I'll say, well, yeah, but soldiers who have lost arms to IEDs will tell you that they feel like their right hand is on fire or is horribly spasmed or cramped, but there is no right hand. So clearly the pain isn't happening in the right hand, even though that's what it feels like for the person. Where's that pain happening? And people sort of think about it and they go, oh, well, I guess it must be happening in the brain. And I'm like, right. And that's where your pain is happening as well. So there's certainly a centralized pain processing component. Another piece of this that is looking more and more important is dysbiosis, which is a disruption of the ecology of the microbiome, all the symbiotic bacteria that live in our bodies. A huge percentage of our symbiotic bacteria are in our gut, where they help us digest food and do all kinds of signaling about weight management and also mood. They're also an important part of our own immune system. So all of this ends up leading to visceral hypersensitivity. That is, IBS patients are going to feel normal gut activity. Just like panic patients, they will often tell you that they can feel their heart beating just by sitting quietly, not putting their finger to a pulse point. But for sure, what they feel is gut activity. So normal sort of peristalsis and gas bubbles and so on may be very, very, very noticeable to them. So they're going to focus their attention on those gut sensations. There's going to be a lot of vigilance, and there is some even in vitro evidence that the pain receptors may actually be too sensitive and too responsive. So why does stress matter? Well, stress biologically, one of the things I always tell these folks is, look, just because it's in your brain doesn't mean it's all in your head. Of course, things are happening in your gut that are contributing to all of this. When we get stressed, there is, of course, a cascade of neuroendocrine responses that have direct physical effects on the GI tract. So, for example, there are corticotropin-releasing hormone and serotonin receptors in the wall of the gut. So when we are stressed and our brain signals our adrenal gland to start producing a whole bunch of cortisol, that has an immediate and direct effect on the functioning of the gut. And sympathetic activation, depending on where it sort of mostly is affecting the person, can lead to reflux, nausea, globus, sort of a tight throat, cramping, urgency, diarrhea, and even spasms in the sphincter and pelvic floor that can lead to difficulty with evacuation and contribute to constipation. Okay, so how on earth can CBT help this? Well, there's a pretty standard protocol for this that's going to be very comfortable and very familiar for anyone who's done CBT for pretty much almost any other problem. We're going to start with psychoeducation and a review of the diagnosis because, of course, you have to get buy-in, and you really do want to be sure that they don't have an underlying inflammatory bowel disease that hasn't been caught. Then we're going to teach relaxation strategies to turn the stress off, particularly deep breathing. We're going to encourage folks to exercise more, which is going to burn that stress off because, of course, that whole endocrine soup is there to fuel, getting away from a saber-toothed tiger. That's not so helpful if you're sitting in rush hour traffic wondering where the closest bathroom is. We're going to teach decatastrophizing, sort of all the basic cognitive model, looking for distortions in their thinking and teaching them how to do that. It's going to involve exposure therapy for sure. We got to get people to stop avoiding feared situations, but also feared foods and feared sensations, very similar to panic disorder. We're going to reduce avoidance in general, including subtle avoidance. We want to get people to stop scoping out bathrooms and overusing antidiarrheal or laxative medication. And we want to encourage acceptance and reinterpretation of visceral sensations. So that's kind of the basic model for CBT approach to IBS. All right, relaxation training. You all know how to teach this. We really want to get people to turn off the stress response. Deep diaphragmatic or belly breathing is going to be especially helpful because it not only maximizes heart rate variability, it actually also optimizes intestinal motility. And some people, when they get good at it, can kind of turn off that cramping urgency response. So I'm a big believer in deep diaphragmatic breathing. I teach my panic patients, I teach my IBS patients. It really gives people a sense of control. You can teach it to them at the very end of the last session and they can walk out of there feeling like they have a tool that they can really use. Of course, you can also teach progressive muscle relaxation, relaxing imagery, and so on. Exercise is going to burn off that neuroendocrine soup. Just getting people to walk. If they don't enjoy exercise, just even getting them to walk is really going to be helpful for many of them. Okay, catastrophizing. Here's where we start to see how the cognitive model can be fine-tuned specifically to treat IBS patients. So IBS patients do a lot of different kinds of catastrophizing. They for sure catastrophize pain. So there's a lot of pain catastrophizing that happens. People really, really worry about what those signals mean. I recently had one patient say to me, what if my whole GI system just shuts down completely? I could die. So these are really, really catastrophic, scary thoughts. But that's only one form of catastrophizing. People with IBS also catastrophize the potential social and occupational consequences of GI symptoms. And that's where it starts to bleed in more into almost like social anxiety. Okay, so what's the evidence of catastrophizing? This is an old study. I'll kind of jump through this quickly. We compared healthy controls, folks with Crohn's disease, which is one of the inflammatory bowel diseases, IBS, and panic disorder, looking at GI symptom severity. And here you can see the folks with Crohn's and the folks with IBS have about similar symptom severity. But when you look at catastrophizing, the folks with IBS look more like extreme versions of panic disorder, whereas on the particular measure we were using in that study, folks with Crohn's didn't seem to be catastrophizing much at all. So that was an interesting finding. But IBS as a stressor, here's the thing, IBS becomes a stressor in and of itself. So common stressors, like giving a talk, for example, live, can become hugely stressful if you're entertaining a lot of catastrophic cognitions about what might happen if your gut acts up, that the pain's going to be intolerable, you're going to have to leave, you're going to have to run to the bathroom, people are going to think you're incompetent, you're going to be humiliated, or worst case scenario, you try to tough it out and you end up having an accident in your pants, which in a live, conference setting would feel really catastrophic for people. So I actually ended up developing a brief self-report measure to look at the tendency to catastrophize. Sample items, if I have to interrupt a meeting or presentation at work, people are going to think I'm incompetent or unreliable. It does a really nice job of distinguishing folks. So again, we used Crohn's disease as a very strong control, and you can see that even compared to Crohn's, folks with IBS are really catastrophizing a lot. Although on this measure, folks with Crohn's are also more distressed than our healthy controls. All right, beyond catastrophizing the specific GI symptoms, fear of food turns out to be a huge issue for these folks. So I did recently with Hannah Zickgraf, who's done some really wonderful work on ARFID. We developed an 18-item self-report questionnaire. This one isn't published yet, but we're getting to it. Comes out to about 5 factors. Avoidance of food for fear of GI symptoms. That's a big one. Lots of folks with IBS will just fast for long periods of time in order to try to avoid GI symptoms. The food itself starts to feel like the enemy. It starts to feel dangerous. It starts to feel like something that's going to hurt you. Social interference. When you start restricting your food to a very small, narrow range of safe foods, you really interfere with social opportunities. And loss of pleasure. People really miss often the foods that no longer feel safe to eat. So this is just a quick graph showing the sort of by diagnosis, where we've got controls over on one side and then sort of picky eaters, folks with true avoidant restrictive food intake disorder, folks with eating disorders, folks with inflammatory bowel diseases, folks with IBS, folks who meet a diagnosis for ARFID but are specifically afraid of the consequences of eating food, and then in that last column, comorbid folks who often have a diagnosis of both IBS and ARFID or something like that. And you can see that they've got the highest scores. Beyond fear of food, fear of incontinence is a huge issue for these folks, especially for folks with diarrhea and urgency. But again, even some of the constipation predominant folks have this fear. Often these folks have experienced a single episode at the onset of their IBS, often linked to an illness and then a post-infectious IBS. And in some cases, there's no question that biofeedback and pelvic floor exercises can help. When there's inappropriate spasming of the colon or the anal sphincter muscles, sometimes this can actually help. But really what we need to do is to reduce catastrophizing. Now, when I used to give this workshop a few years ago, people would ask me, well, what is the incidence of incontinence in this population? And we had no idea. So last year I did a study to find out, and it turns out it is pretty high. It's higher than I expected. What I'm showing you here is the results for a very restrictive sample. It still had about 380 people in it who absolutely met Rome 4 criteria for IBS with no other GI comorbidity. 62% of these folks have experienced at least one episode. And actually, no matter how we sliced and diced the sample, even folks who met the older Rome 3 criteria where they had pain slightly less often, no matter, or if they had GI comorbidity, no matter how we sliced and diced it, it was just a little bit more than 60%. Of folks have experienced at least one episode of fecal incontinence, although close to 40% have never experienced it. And a relatively small group has experienced it more than 10 times in their life. But here's the really fun finding. Fecal incontinence does impair health-related quality of life. There's no question in a linear fashion, as you can see from this graph, but not by much. It's not actually explaining much of the variance, amazingly. So on the y-axis here, we've got the IBS quality of life scale scores, which is an IBS-specific health-related quality of life measure. And I've shown you kind of the range of scores that people tend to be in. And what you can see is that actually almost everybody's in the moderate range. You know, the folks who are having more than 10, you know, some of the folks at the top of that definitely start to get into the more severe range. But really, it's fear of fecal incontinence that drives this, even if the person has never had a single episode. And here we can actually just show percent variance in quality of life in a, you know, multiple regression model. That first measure is the catastrophizing measure. The second one is the visceral sensitivity index, which is Jen Labus's wonderful measure that's sort of like an anxiety sensitivity. Depending on which one you enter first, they each account for unique variance, but there's a lot of overlap between them. The next is the fear of food questionnaire. Then we've got actual Rome 4 severity, so the severity of the actual physical symptoms. And what you can see is that above and beyond that, fecal incontinence severity predicts no variance whatsoever. So if what's really driving the distress and a lot of the disability is the fear and avoidance, obviously CBT is going to be a great approach for these folks. So we're going to use all the components of classical cognitive therapy. But you then have to progress to evaluating and examining IBS-specific catastrophic beliefs. So that's why it's helpful to know a little bit about kind of what kinds of things these folks often are afraid of. And you can explore, obviously, the specifics and details with everyone. So I really want you to think about this as very, very similar to Dave Clark's model of panic, because it really is a very similar thing. So things are going to start with an initial GI sensation. People will often say, well, I noticed a twinge, or I noticed some butterflies, or I noticed a little spasm somewhere, or I felt like, ooh, I might need to go to the bathroom. That then triggers a cascade of negative automatic thoughts, sort of catastrophic thoughts. Oh no, not again. I can't stand it. I'm going to have to leave. This is terrible. Everyone's going to think there's something wrong with me. I can't stand this. Of course, that immediately makes people anxious, which triggers a cascade of increased sympathetic arousal, which leads to worsening GI symptoms, which feeds increasing visceral sensitivity. And you're off in this vicious circle. And then people are having a full-blown IBS attack where they do feel tremendous cramping and urgency. So where are we going to cut this cycle? Well, deep breathing, obviously, is going to start to reduce some of that sympathetic arousal and give people some more perceived control. That's very helpful. Even better, cut it here, do some cognitive restructuring so that you can take away those negative automatic thoughts. Ultimately, this is what you're going for. Oh, I've got a little twinge down there. Well, so what? It's okay. So let's spend a few minutes now talking about avoidance. In addition to food avoidance, as I pointed out, IBS patients often start to avoid lots of classical kind of agoraphobia related places. So any place that might trigger an attack, particularly places involving food. So a restaurant, a bar, dinner at a friend's house, a work event where there's going to be hors d'oeuvres and drinks and so on. And any place from which escape to get to a bathroom might be difficult, embarrassing, or too time-consuming, potentially leading to incontinence. So all different kinds of transportation, crowded public places, concerts, ballparks, your kids, soccer tournament at this enormous set of fields with 3 porta potties that might be a quarter of a mile away, beaches, parks, going for hikes, concert venues, any movie theaters, any place where getting up and getting out to a bathroom quickly and easily might be problematic, any place where there's going to be long lines for the bathroom and so on. Subtle avoidance is often the hardest part to tackle. And this is really similar to safety utilization behaviors in panic disorder. People will scope out bathrooms in advance. You all probably don't know, but the makers of Imodium ever so kindly have a bathroom finder website where you can log in and put in an address and find all the nearby public restrooms. Always sitting in the back or on the aisle, planning routes to the bathroom, wearing loose, comfortable clothes that won't press on the abdomen. And my favorite, carrying antidiarrheal, anti-gas, or antacid medications kind of at all times. These folks will use Imodium and Lomotil the same way panic patients use benzos. There are quick dissolving Lomotil tabs that they can put right under their tongue, and people will feel so much safer when they have those. But it's really all still aimed at avoiding GI sensations and the possibility of embarrassment, discomfort, or distress. So it's one of the things that you're going to have to tackle with these folks. So how are we going to do it? Exposure therapy. We absolutely know that some component of exposure is a crucial active ingredient in every successful treatment for IBS, including gut-directed hypnotherapy, which is the other kind of empirically supported treatment for IBS. But they're still focusing people's attention on it and reinterpreting the sensations. So it really works just like exposure therapy for panic disorder or specific phobias. You're going to start by creating an anxiety hierarchy. You're going to work your way up the list and carving things into small, manageable chunks. For example, I might suggest to someone who's terrified of driving around in the car that, they go drive around their own neighborhood for 30 minutes till it gets boring, or even just sit in your car in your own driveway for 30 minutes just till you get boring. And we know that this will actually help reduce visceral sensitivity. Now, most of your patients who come in with IBS are going to tell you that they are either on a highly restrictive diet or have tried every diet under the sun. And maybe some of them have been helpful, at least for a while, and maybe some of them aren't. But now they are just sort of afraid to eat just about anything. Unfortunately, restrictive diets are by far the most popular approach to IBS, and that's in both patient surveys and in surveys of how gastroenterologists actually manage this disorder. What everyone's going to say is try a restrictive diet. And if you go on Amazon and just Google IBS under books, this is what's really mostly going to pop up. So here's the truth about food and IBS. There are no universal trigger or danger foods. Fear and avoidance of foods is one of the most distressing aspects of IBS and greatly decreases quality of life. Most elimination diets are going to help no more than any other placebo. About 30% of people are going to say they feel better. And getting people to stop obsessing about and micromanaging their food and start eating healthful, varied diets is really crucial to successful treatment. Now, in the last few years, there has been some more good science on restrictive diets, and the low-FODMAP diet, which I'll get to in a minute, does have some evidence base behind it and some clear scientific thinking about why it might be helpful, but it's very problematic for reasons I'll get to. However, a lot of your folks will come in and say, oh, I'm gluten intolerant. Unless a patient has celiac disease, for the vast majority of people, there is no reason to avoid gluten. Avoiding gluten has lots of downsides. Gluten-free foods, replacement foods are very expensive. It's inconvenient. You can't eat out. Lots of favorite foods. And it's actually really hard to be truly gluten-free. I mean, people with celiac disease who really have to do this will tell you that there's hidden gluten in a lot of things, like soy sauce, for example. So you got to be vigilant and knowledgeable to do it. Now, unless a patient has a milk protein allergy or severe lactose intolerance, there's probably no reason to avoid dairy. And even people with lactose intolerance can usually digest fermented foods like yogurt, cheese, kefir, buttermilk, or they can use lactate products for most of these folks. Again, we really want to emphasize that avoiding food reduces quality of life, and we really want to get people back to eating a healthful, varied diet. So the low-FODMAP diet, which I mentioned, FODMAP stands for, you ready? Fermentable oligo-di-monosaccharides and polyols. Had to practice that a few times. The FODMAPs are carbohydrates that are co-digested by symbiotic bacteria in the small bowel. That's what the F stands for. That's what fermentable means. Fermentation is done by either yeast or bacteria, and it's our symbiotic bacteria that help us digest all of these foods. In fact, these foods constitute all of the prebiotic foods because they feed the symbiotic bacteria that make up our microbiome and are essential for good health. Now, they do reliably cause more gas and water content in the gut for everyone. They do. There's no question about that. But interestingly, they do not cause any more gas and water content for people with IBS. People with IBS are just more bothered by it. In other words, it's only problematic in the context of visceral hypersensitivity. So restricting high FODMAP foods, and there's a 6-week very, very strict elimination phase, and then an ongoing sort of very careful, small amounts, reintroduction of one food at a time phase to see how much of which kinds of foods people can tolerate. Now, restricting high FODMAP foods does reduce GI discomfort for people with IBS. It does, better than placebo. It's hard to do those studies well, but the folks at Monash who created this diet have really done studies about as good as you can do with kind of, you know, controlled diets and so on. And it really does seem to reduce discomfort for people. But it is extremely restrictive. It is very meat heavy because it requires almost complete elimination of both dairy and legumes. So if you've eliminated dairy and legumes, you've basically got meat as your primary protein source. It's hard to get good nutrition on it. It eliminates tons of fruits and vegetables. It's extremely difficult to maintain. It is impossible if you don't control your own food. So for example, if you're a college student eating at a dining hall, it is impossible to maintain this diet. More problematic, though, is that the long-term effects on the microbiome are really worrisome. There is increasing evidence that, for example, bifidus bacteria die out completely. In other words, dysbiosis increases, and it works via the opposing mechanism of CBT. So low FODMAP is trying to avoid or eliminate the sensations that IBS patients are sensitive to. CBT, of course, is using exposure to eliminate the hypersensitivity, which I think we can all agree is probably going to be a better approach. So you want people to eat sensibly, stop limiting their food, stop avoiding whole classes of food, and stop catastrophizing every single little sensation that they've got in their gut. Okay, so what evidence is there that CBT works? There's a ton. I'm going to highlight just a couple of studies. This was an early study I did with Modest. It was online with Modest therapist feedback. You know, 6 basic modules. We got pretty nice results from that. You can reduce GI symptom severity, improve quality of life, and we were able to find that indeed the results were mediated by reductions in both catastrophizing and visceral anxiety, which was very satisfying. Brianne Lotson and Gerhard Andersson, the folks in Sweden, have done another series of trials which are excellent. They also did an internet-delivered CBT. It was a little bit more focused on acceptance and exposure than explicitly on cognitive restructuring. They got great results. Our effect sizes were almost identical. Michelle Krask and folks out at UCLA have done a similar kind of study where they compared attention control to cognitive stress management to an interoceptive component, an interoceptive exposure focused treatment. And you can see that on both the IBS severity score and on the visceral sensitivity, the interoceptive exposure component was the most powerful. Their effect sizes were a little smaller. I think they sort of stripped the treatment down just a little bit too much. So I do like a more a combined treatment. In the most recent study, Jeff Lackner, who's done some great work in this domain, has been comparing a standard in-person CBT to a minimal contact CBT with a whole bunch of home study to an education control. And one of my favorite findings about this is that they're actually finding that the minimal contact CBT condition is getting the best results. So giving people a little bit more ownership, really having them do some bibliotherapy at home and take responsibility for doing a lot of that work actually seems to be working the best. So that's very exciting. So what that suggests is that this is pretty amenable to self-help. So I did actually rework that initial internet intervention into a standalone self-help book. And because Diane Chambliss is my boss, I couldn't just go publish it. I had to actually test it in a randomized control trial before approaching trade publishers. So I did that. I have to say, I was shocked. We got really surprisingly large effect sizes, given that we eliminated the therapist component completely. In fact, the effect sizes were really comparable to the internet-based study. So, you know, consistent with Lackner's most recent findings, the more ownership you give people, they really seem to do well. So you can see our Cohen's D's are all in the large to very, very large range here on all of the main outcome measures. So we were very pleased about that. So I just want to say that my book is indeed available, Reclaim Your Life from IBS. Jeff Lackner also has a self-help book that was written a few years before mine. I think it's good. I think mine's better. I don't think that this is exactly the intervention they're using in their minimal control condition. In any case, they're both out there. They're both worth a read. They'll both give you sort of the basic approach, and they're both written for patients, so you can use it as adjunctive bibliotherapy. All right, so quickly now, I want to talk a little bit about how to adapt these treatments to IBDs. You might remember that in a number of my early studies, looking at some of these basic cognitive processes in IBS, I was using folks with inflammatory bowel diseases as a kind of strong control because they have such similar physical symptoms, but rates of psychiatric comorbidity tend to be lower. And in the process of doing that, what I found was that I ended up with a bunch of people with IBDs telling me, hey, you know, we could actually really use some support too. So could you please adapt this treatment and make it relevant for us? So I thought, well, okay, that's a great idea. So first I tried just kind of tweaking my book, and then I really realized it needed to be a whole new intervention. So that's where we're at with this now. So IBDs are autoimmune disorders. They need to be confirmed with, you know, histology and pathology. The main symptoms are abdominal pain, diarrhea, nutritional deficiencies, and fatigue. And they can lead to serious and life-threatening complications, and they often require corrective surgery. Again, either resection or emergency surgery to clear out small bowel obstructions. So these are not trivial. So is there a response to psychotherapy? Well, I'm not the only one who's been doing this. There's another couple of wonderful groups. There's Makaka Wallace in New Zealand who's done some great work on this. There is minimal evidence from one well-done trial that you can actually get some movement on disease severity, that is on objective inflammatory markers like the fecal calprotectin and blood markers, and that they can be impacted positively by psychosocial interventions. That was one trial, but Makaka Wallace has really done the definitive, big, well-done in-person CBT trial on this, and they unfortunately found no impact on disease markers. Which was disappointing, but they did get substantial improvement in depression, anxiety, and quality of life. So these folks can definitely benefit from support. And my clinical experience, sort of psychological adaptation, how psychologically healthy a person is, and their quality of life is really not well correlated with disease severity for these folks. So you'll get people who have very severe disease who are coping just beautifully, and then you'll get another person who has equally severe disease who is almost completely disabled and miserable about it. So clearly there's a lot of work that we can do to help improve coping for these folks. So what is the psychiatric comorbidity for these folks? Different outcomes across different studies, kind of depends on whether it's self-report or interview, or, you know, definitely lower rates than in IBS, but definitely higher than in the healthy population. Having an IBD can be quite stressful. I'll give you an example. A woman I met at a support group who ultimately sort of came into my private practice for some sessions. She described going in for an ostomy surgery and feeling extremely anxious. An ostomy surgery is where you actually might have an external hole created in your abdominal wall, and you would drain the feces into a bag for a short time, often while a resection surgery is healing. So she was going in for this surgery. She was very anxious prior to the surgery, and the nurse came up to her and said, well, what do you usually take for anxiety? The patient said, I'm not usually anxious. This is really anxiety provoking. So I think the medical community doesn't always quite understand how anxiety provoking this kind of thing can be. And interestingly, these folks are vulnerable to secondary IBS even when the IBD is medically in remission. Now, of course, for them, those GI sensations might in fact have signaled a life-threatening emergency. So it's not surprising that they've become somewhat hypervigilant and sensitive to those sensations. But remember that these folks are still catastrophizing a bit. Now, some of the items on the GI cog, which is what this is showing, are things like it's the pain catastrophizing in IBS. So when I have GI sensations, I worry that something might be seriously wrong. Now, that might be entirely appropriate for somebody with Crohn's disease. They might indeed have something seriously wrong. But there's other kinds of catastrophizing that they are also somewhat vulnerable to. So initially, I took the IBS intervention and kind of adapted it. And we did a small kind of pilot RCT with a bunch of folks with IBD, and we included a therapist feedback component. Now, treatment completers did, in fact, experience pretty significant relief. Quality of life went up. Visceral sensitivity and catastrophizing and depression and distress over GI symptoms all went down. GI symptoms themselves didn't shift much, but distress over their symptoms did go down. And completers clearly found the workbook kind of supportive and helpful, which I was really pleased about. But you'll notice, I don't actually have the effect sizes on these graphs, but you'll notice that the magnitude of the effects is smaller than it is in IBS, and that's kind of to be expected with these folks. The CivDQ graph on the bottom right of your screen is the standard health-related quality of life measure for folks with IBDs. So we kind of fell back and we thought about it, and I decided that I really needed to not just have a sort of revised or tweaked version of the IBS book. It really needed to be its own standalone book. So I completely retooled it, wrote whole new chapters on diet and ostomies and medical management and so on. Sought out stakeholder feedback from both a number of IBD patients and from physicians, and we really revised it to make it much more IBD specific. There really do need to be a number of differences in the approach for these folks. For example, carrying a change of clothes and antidiarrheal medications might be a maladaptive avoidance behavior for an IBS patient, but it might be entirely adaptive for an IBD patient. IBD patients do indeed are at much higher risk for fecal incontinence. The risk for fecal incontinence in their case is directly correlated to tissue damage, especially in the colon and around the anal sphincter muscles. So the more severe the disease, the more likely they are to experience occasional incontinence. So for these folks, what you want is for them to feel empowered to go out and about in the world, even knowing that there is a risk of this happening, because what you don't want is for them to start avoiding life and just staying home all the time because they're too afraid to go out. I had one woman in my practice with a very, very, very severe IBD who unfortunately was not a candidate for corrective surgery because she was also a very heavy smoker. And she had actually developed what's called an anal vaginal fistula, which is a small hole that forms between the last part of the colon or the anus and the vagina. So unfortunately, she was actually leaking liquid feces a little bit through her vagina, and there was no way to control that. She was absolutely convinced that everyone could smell it. Interestingly, the only thing you could smell when she entered the room was cigarette smoke. So what we really ended up working on was to help her quit smoking so that she could then go have the corrective surgery and have it have some chance of success. So there's still a lot of, it's a real problem, there's no question, but there's still a lot of cognitive distortion that happens for these folks. So they really need to learn to distinguish between informative pain that might signal a true flare or an obstruction and centralized pain, which is more likely to be secondary IBS. But still, the CBT model can help a lot with coping and problem solving for these people. There's a lot of secrecy, there's a lot of shame. A lot of times people don't want to tell other people in their lives about these things. So you really want to encourage behavioral experiments with honesty. Tell people in your life what's going on. Not all the gory details, but just, hey, I've got some chronic GI disorders. So did that one help? Well, we subjected that one to another RCT, this time with an active psychoeducational control condition rather than just a wait list. Treatment completers did indeed experience clinically and statistically significant gains sort of across the board, which was great. Oddly enough, the psychoeducation group also experienced some gains. There's a lot going on in this graph. What you're seeing here is the two columns on the left of each graph are the initial post-treatment results after the 6 weeks of treatment. The bars on the right are the 3-month follow-up results after the folks in psychoed were crossed over to CBT. So you can see that we get some increasing gains in things like catastrophizing and visceral sensitivity when they get both treatments. But that indeed the psychoeducational group itself was actually somewhat helpful, which kind of surprised us. This graph is a little complicated. There were a number of people who did go into flare, and they were actually still had better quality of life in flare than they had at baseline. So even though these graphs don't look super impressive, we were actually pretty pleased with these results. We were left with this sort of confusing question, which is, why was the psychoeducational control condition so helpful? When we were writing it, I kept saying to my students, remember guys, this is supposed to be a placebo. I don't really want it to do anything. And my students kept saying, Dr. Hunt, we really think this is going to be helpful. And it was. And I think the reason is that a lot of IBD patients just get very, very little education. And so they go to Dr. Google. If you go to Dr. Google for inflammatory bowel diseases, you very quickly see terrifying, terrifying text. This is one click away. Severe colitis. The mucosa is grossly denuded and the patient had her colon resected. 2 clicks and you've got a Frankencolon where there's been a J pouch put in surgically. And then 3 clicks, you've got someone showing you how to clean a permanent ostomy. So these are really terrifying, terrifying images and thoughts that are sort of worst case scenarios that haven't been contextualized for these folks. So in summary, both IBS and IBD patients can benefit a great deal from CBT. For many IBS patients, CBT is actually going to be curative. For IBD patients, CBT can lead to improvement in depression, anxiety, coping, and quality of life. For many patients, an evidence-based, empirically supported self-help treatment may be sufficient. For more distressed patients with a lot more psychiatric comorbidity, obviously having a GI knowledgeable clinician who's expert in CBT may actually be crucial. And that's now you guys. So hopefully that's kind of hit every point, and I guess we'll turn to questions now.
Awesome. Thank you very much, Dr. Hunt. Like Dr. Hunt said, we will now be taking any last-minute questions about today's presentation. As a reminder, you can still submit questions through the chat box in your attendee control panel.
All right, so Astrid, are you going to read these, or shall I go ahead and start?
You can go ahead and read them if you'd like.
Okay, so let's see. Somebody asked what is FODMAP, but I think we got to that. Do avoidance behavior and CBT to treat it look the same for IBS and IBD? Are there special things to consider in persons who also have an IBD? So yes, as I pointed out, absolutely, there are differences. In fact, sometimes we might want to encourage folks with an IBD to adequately use antidiarrheal medication. So for example, if they've had their bowel resected at some point, the place where that heals is called an anastomosis. It's often a little bit narrower than the rest of the gut. They may be terrified of using antidiarrheal medications because they're afraid it could cause a small bowel obstruction. Now that might be true in the immediate aftermath of the surgery, but almost always the gastroenterologist is going to say, no, it's fine. Feel free to use Imodium. So there we want to kind of decatastrophize their worries about adverse effects from using medication, symptom control medication appropriately. And we might actually want that person to use Imodium and not to be afraid of it. So yes, there are definitely ways in which things need to be different. So another person has written in, I'm working with a woman in her 20s who's doing very well with CBT for IBS, great. However, she says she passes gas much more than most people. With our work, she's taken a light approach to this, including laughing about it with her friend, but she will not date, oh my, because she feels it will be too embarrassing if she passes gas on a first date. Any suggestions for a behavioral experiment she could try? This is a great question. So one of the first things I like to ask people who are really worried about gas and farting is, how many times a day do you think most people fart? And they'll say, well, you know, if you don't have a problem and you're polite, then you don't fart at all. That's totally not true. Women on average fart 6 to 10 times a day, and men on average fart 8 to 12 times a day. So yeah, guys are a little grosser. That's because gas happens. Gas is a normative part of digestion. The vast majority of the time, we're simply unaware of it. So again, getting people to kind of decatastrophize that and normalize it, and getting somebody like that to really think through, well, what would the worst part of farting on a date be? Like, is it super loud? Is it super stinky? Are you sure the person's going to notice? What do you think the person is going to conclude about you? I would really challenge the underlying catastrophic distortions there. Now, if she really does have terrible gas and stinky farts, you can certainly suggest to her that she consider probiotic. Reestablishing some heterogeneity in the microbiome can sometimes help with that. But I think the important thing is for her to not be afraid of it. How can I attain a copy of your slides? I think Astrid said that they will be downloadable at this. Another question, do you recommend having patients track GI symptoms weekly? And if so, is there a form that you recommend? So that's interesting. I actually don't. I don't like having people keep symptom diaries. I think it gets them refocused on sort of the pathology. IBS patients are coming in, and it's sort of like a panic patient coming in and saying, I just don't want to be anxious anymore. Please help me not be anxious. That's not really the right goal. And in the same way for IBS patients, they're going to come in saying, I just want to stop having all these GI sensations. I just don't want to feel this anymore. Again, having people track their symptoms would seem to be in service of tracking recovery and seeing if we're starting to minimize symptoms. That's not really the goal. That's not really what we want to do. We want them to be able to have normative experiences of GI symptoms and not catastrophize it. So I actually do not recommend weekly symptom diaries unless it's part of an ongoing clinical trial. Can we get a copy of your social? But they didn't finish writing the question, so I'm not sure what they mean. Why try to normalize farting, then say, yeah, guys are grosser? Good point. Because humor is really, really, really important in working with these people. Poop is taboo. It is kind of gross. It is kind of dirty. It is kind of stinky. And every single culture in the world makes it taboo. Incorporating humor and helping people reduce their disgust sensitivity and just being very frank and funny about some of this stuff is really important for working with a lot of these patients. So I hope that makes a little bit of sense. How to obtain a copy of your social occupational catastrophizing questionnaire. It is published in, I believe, Cognitive Therapy and Research, and the scale is in the appendix of that, but I'm also happy to make that available for people. If anybody wants to email me, mhunt@upenn.edu, I am happy to send you a copy. And let's see. Yep, that seemed to be what a lot of people wanted. That seems to be it. Oh my gosh, and I'm even finishing on time, astonishingly.
Thank you so much, Dr. Hunt, and thank you everyone for attending today's training. So everyone will receive a follow-up email shortly after that includes the link to the webinar evaluation, a copy of the webinar recording, and a post-test assessment for those seeking CE credits. If you'd like to take the post-test assessment after this webinar, please stay on the platform after these few announcements. All right, thank you, Dr. Hunt.
Thanks, everybody. Bye-bye.
Our next ADA Live webinar will be held on Thursday, January 24th at 12 p.m., titled Empowering Families in the Face of Pediatric Acute Onset Neuropsychiatric Syndrome, featuring Lynn Sicklin and Tamara Chansky. If you're not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. Please visit ada.org to learn more. We would also like to invite you to register for the ADAA's annual conference on March 28th to March 31st in Chicago. On behalf of ADAA and our presenter, we thank you so much for joining us today.